A very good morning to one and all present here. I thank Dr. Nishant for having me in his instruction course. So a warm welcome to all the delegates who have come early Sunday morning. And I'm Dr. Srinivasa Raghavan, and I'm a senior cataract refractive surgeon based at Dr. Agarwal Eye Hospital, Gachibowli in Hyderabad. And today I'm going to speak about a newer topic, I would say. You would have all heard about monofocal ICLs, but what I'm going to talk about are the multifocal ICL. And I have no financial interest associated with this topic. And I will be the multifocal phakic IOL. I would like to term it as multifocal phakic IOL because I will be covering two things. I'll be covering the multifocal ICL from the Star Surgical, and I'll also be mentioning few words about the IPCL presbyopic, which is already available. Both are only posterior chamber implantation phakic IOLs and phakic IOLs. A little bit about the ICL material and advantage before we go into proper multifocal ICL. These are implantable columnar lenses. These are type of posterior chamber phakic intraocular lenses by Star Surgical, which was launched in around 1993. They are 100% biocompatible, soft, flexible gel lenses. This patented material is made up of 60% poly hydroxyethyl methacrylate, water 36%, and benzophenone 3.8%, and 0.2% collagen. And in many studies, they have been proven very safe. They have safer alternative to refractive lens exchange also, which carries a risk of retinal detachment and loss of accommodation. And the phakic intraocular lens has been conveniently and conventionally used for high degree of refractive error or when corneal refractive surgery is contraindicated. Reversibility is the main advantage. No additional space like a LASIK machine which needs or a specific instrumentation is required. Your basic good biometry with a decent topographer and hands of a good surgeon. This is a very safe procedure. And currently there is one FDA approved posterior chamber intraocular lens, which is the ICL, which is the implantable columnar lens. This is just to show the various models. Initially, we were having a plate haptic lens, which is plano concave, and which has got the directional holes. I will be talking more about this when I go to the video. The next generation and the latest generation has got a sentry port as well, which will help us not have a pre-operative procedure like a peripheral iodectomy, but it is still safe. And this is the place where the IOL is placed, that is in front of the clear phakic lens and behind the iris in the sulcus. And just a little bit about evolution. Why I am talking about this is because the latest model of multifocal ICL is also based on this. The ICL is a rectangular one-piece plate haptic design, which is plano concave. We were using the Visian ICL4, and it has been commercially available since 2011 to correct myopia. Toric version was approved in 2018 to correct or reduce myopia with astigmatism. Both lenses are available in 4 lengths. This is important because sizing of ICL is very important. It is 12.1 mm, 12.6, 13.2, and 13.7, and it is around 7.5 to 8 millimeter wide. The V4C, which is the C actually denotes the sentry port, or the EVO model as we say, features a central port or a hole of 0.36 millimeters. It's called an aqua port. It means to eliminate the need for NDI iridotomy, as I said, that was required in patients who had previous model ICLs. The port is meant to allow the physiological aqueous humor circulation. The lens also has an ultraviolet absorbing chromophore. So following the eVivo model, which is the V4C, we have the eVivo Plus. Currently, most of us are using the eVivo Plus ICL model V5. This has got a broader optic zone, and a very recent addition to this, the trials have been completed. Few other countries other than India have started using it. This is eVivo Viva. It's based on the same sizing and large optic zone. It has got a large optic zone up to 6.1 millimeter and can be used to correct residual refractive error after cataract surgery as well, as a normal 360 micron port in the center of the optic, which, as I mentioned, this is for the aqueous flow. And so this is this EVO plus ICL and historic version were both FDA approved in the United States in March 2022. And we have a long-term published safety results for these ICL. So with the same platform, the multifocal ICL is going to come up, and we believe that it is going to be very, very safe. So safety first, and then this is an innovative double solution, and this is this will correct myopia as well as presbyopia. The Vivo Viva, which is the multifocal ICL. This is a clinical study which has told about the performance and safety of the extended depth of focus implantable collamer lens. This is based on EDOF platform, unlike the ICL, which is based on the multifocality diffractive platform. And the company has not given great details with respect to the designing. It has been, this is a Star EVO Vision implantable collamer lens with aspheric optic, and it is referred to as extended depth of focus implantable collamer lens, or the EDOF ICL, and a novel approach to surgical correction of refractive error and presbyopia in phakic patients, and includes a combination of most advanced elements of ICL platform, including an increased optic diameter to note, the central port KS aqua port, and an aspheric design, which is theoretically intended to provide up to 2D of extended depth of focus, basically. So the primary performance endpoint which were analyzed was the achievement of monoocular uncorrected near visual acuity of Snellen's equivalent 20/40 or better at 40 centimeters 6 months after the implantation, and equal to or greater than 75% of the implanted eyes. These were the main thing which was looked for. And the indications which is being told is EVO Viva ICL is indicated for phakic patients 21 to 60 years of age, or pseudophakic patients 21 years and older with an AC depth of 2.8 mm or greater, to correct or reduce myopia with or without presbyopia, because we can also use it for 21 years of age. That's why it is mentioned with or without presbyopia, ranging from minus 0.5 diopters to minus 20 diopters. As explained, is intended for placement in the posterior chamber. So this is a design. The main point in which I wanted to let you know is, for all the ICL users, we know that the markings will be with right side up. So the leading haptic, when it goes inside the eye, you should have the marking in the leading haptic to be on your right side. In the eVivo Viva, it will also have a partial hole on the right side near the optic design. So this is the design variation which will help us identify what is the lens which is being implanted. And the studies have also told that there is no decrease in contact sensitivity, and there is a lot of improvement in visual acuity at all distances. But because this has been aimed to get the extended depth of focus and a near vision comparison at 40 centimeters, it is better if we plan it like how we plan for a normal EDOF multifocal IOLs, with a micro monovision correction, especially with a myopia in the non-dominant eye. So it requires bilateral implantation for a better performance, and we can aim a micro monovision with a minus 0.75 at least in the non-dominant eye. This is the approved range. This is not present for astigmatism and not available for astigmatism above 0.75 diopters as of now. And it will be coming up with the same sizes like 12.1, 12.6, 13.2 and 13.7 with minus 0.5 to minus 18. And as said, up to plus 2 diopters, it will be very comfortable for near. So going on to the preoperative evaluation of this multifocal ICL, it's very similar to our normal ICLs which we do. A complete ophthalmic examination including uncorrected distant visual acuity and corrected distant visual and near vision acuity. You have to do a cycloplegic refraction, white to white measurement, slit lamp biomicroscopy to rule out pre-existing cataract or any other anti-segment pathology. An intraocular pressure measurement, because we are going to operate and place the IOL in the AC. So very importantly, glaucoma has to be ruled out. I generally even do a OCT RNFL baseline documentation and a perimetry for all these patients. And corneal evaluation, if you have specular, it is good to get the specular done, or only in cases of doubts, if you have a gut day, this has to be definitely done. And if there is a compromise, the IOL is contraindicated. And as with other ICLs, dilated retinal examination evaluation for presence of retinal tears is to be done. Lens sizing, nomograms are available, very similar to what we do for the normal Star ICL. This is basically based on white to white measurement and anterior chamber depth measured from the corneal endothelium to the crystalline lenses. So the white to white, which is actually recommended, is from the OpScan 2, and the UBM will definitely give a better white to white measurement, but UBM is not very freely available everywhere. And this vaulting to be measured post-operatively. The IOL power calculation is performed through the online calculator, which is provided by the modified vertex formula as given by the Star Surgical. So once you send in all your required data, they will be sending you which ICL to implant. This is a small video to just show you the so this is mainly to show, because we as it is very similar to the ICL, always remember this right side up has to be done. This is few pearls for phakic ICL. What parameters we have to watch for, the loading technique and step-by-step procedure. Always remember there should be a 2.8 is a cutoff ACD, and the white to white has to be measured properly. Generally we size it 1 millimeter to whatever white to white we measure, and these are the 2 ports. These are the leading orientation marks in the leading haptic. It should be on the right side, so I always remember right side up is how it has to be implanted, and then the convexity should be up, and then we will have to, these are the axis marker if you are going in for a toric, but in multifocal ICLs we don't have a toric. This will be the center flow. Additional to that, one more port will be available, and this is very important with respect to loading. We have to remove the air bubble because it will be very difficult to wash it later on, and when you pull, you have to always look into the orientation mark and the central marks edge marker. We generally follow this because twisting is very common with respect to ICL. That is one way in which the IPCL is better than the ICL. But long-term follow-up, I always have a follow-up around 10 years of my cases. I feel ICL is much safer. And always see to the orientation marks. Few positions where how the orientation mark can be on either side. The best is to have it all in the center, which means the first, the mark, the second trailing mark, and the cartridge lock. All these, if they are in the center, when you load very carefully, pull the ICL with the ICL forceps in such a way that all 3 are in line. So when you go inside and implant, it will be just a single push. Always implant on the anterior chamber and then tuck the haptics. If there is a twist, you'll have to pronate or supinate your hand accordingly so that when it unfolds, you don't twist it in the opposite direction. So there are few tricks and tips which will help us do it. So if you feel that the leading haptic is on this other side, you will be having you will have to rotate it to the right side. So these are just positions. So that is about the ICL. Just a few words about the IPCL. This is also available in market since 2015. A lot of people have been using it, and this is based on the diffractive rings, as I told before. And this is a case with presbyopic ICL in situ. Few articles regarding with respect to that. These are just the last point, take-home points. Patient counseling is to be really mastered because, as told in every presbyopic discussion, presbyopic correction discussion, you'll have to talk to the patient before you put him up to any point, and always remember under promise and over deliver. Always tell the patient not to compare both the eyes. You have to see binocularly. So even when I see the patient, I tell them come and see with both eyes open. And with respect to multifocal ICL, long-term results are awaited, and availability in India is still awaited. Probably it will take a year for us to get the multifocal ICL. Thank you so much.
Thank you, Dr. Preethi, for this detailed talk. So yeah, it's an amazing procedure. As she said, her final point, always ask the patient to see binocularly.